Hello, I'm Mary Beth Cadlick, and today we are going to be presenting Supporting Emotional Regulation, Language and Sensory Processing Considerations. So I'm Mary Beth Cadlick. I am currently the Program Director of CAN-DO, which is the Center for Autism and Neurodevelopmental Disorders that is part of UMass Memorial Healthcare and UMass Medical School. I'm also a part-time assistant professor in the Department of Occupational Therapy at MGH Institute of Health Professions. And I'll be presenting these slides with my colleague, Sue
Hi,
Swanson.
I'm Sue Swanson. I am a speech language pathologist at UMass Medical School at the E.K. Shriver Center. And I'm delighted to be here with my colleague to share some information about emotional regulation.
So we are part of the training webinar series for the Massachusetts MCI teams. And there are 7 webinars in this series, and we are number 7. Last but not least, but the supporting emotional regulation, language, and sensory processing considerations, just so you have in context what we're covering today. I'm going to review the outline for this webinar. Basically, our goals for this webinar are to review the neurobiological, developmental, and environmental factors impacting emotional regulation. We need to introduce an interdisciplinary framework that honors both the internal and external drivers of emotional regulation, often referred to as problem behaviors, and to do this through evidence-based strategies that improve functioning and quality of life. Also, lastly, we're going to describe specific interactional and environmental strategies and supports that can be utilized to improve emotional regulation, social communication, and sensory processing abilities in meaningful and authentic context, which is where you are working with these families in their meaningful and authentic context in the home and the community. So we're just going to share a little bit about ourselves. I'm going to move our little heads here. So this is just to give you a brief overview of the requirements to be an occupational therapy practitioner. So we have credentials that we are required to maintain, just as all of you. And currently in occupational therapy, if you're starting out to become an occupational therapist, you need a master's or an entry-level doctoral degree in occupational therapy. As part of our training, you have to complete 2 different 3-month clinical, they're called level 2 fieldwork experiences, and also pass a certification exam. And this is all OTs are required to do this. And then we also, our scope of practice is really driven by the American Occupational Therapy Association and in collaboration with their certification board. And really our scope of practice is that we provide client-centered, scientific, and holistic approach to address meaningful life activities. So this is really our North Star, it's my North Star, and we will think about and talk about how this gets conveyed and implemented with the youth that you are working with. And we evaluate occupational performance. This is a term that we use often in practice, and that includes looking at social participation, play and leisure, education, activities of daily living, instrumental activities of daily living, work, rest, and sleep.
So as a speech language pathologist, we are the autonomous professionals who, by and large, are the primary care providers for speech language pathology services. And we specialize in the evaluation and diagnosis and treatment of communication disorders, and this includes autism, as well as intellectual and developmental disabilities. And one of the reasons I'm thrilled to be here today is that the importance of interprofessional collaboration is highly valued within our profession. And as you well know, the youth that we work with often have multiple issues occurring that require many disciplines. So we work together with others to provide best practice. Again, speech language pathologists have board certification requirements. It includes a master's degree in speech language pathology, as well as passing the American Speech Hearing Association board certification exam. So we are board certified. It is called the Certificate of Clinical Competence. And finally, we are required to complete a 1-year clinical fellowship under the supervision of a licensed speech language pathologist for a minimum of 1,300 hours. So I wanted to start with this slide because I think Norm and Emma, who are disability advocates, they are self-advocates, both have disabilities, that they provide us with an important reminder that be still and listen. What you define as inappropriate may be my attempt to communicate with you in the only way I can, or the only way I can exert control over my life. Do not work on me, work with me. And for the youth that we see, it is so often, it's easy to interpret the behavior as being non-compliant, being aggressive. But really, we, as you well know, need to enter into the crisis situation as partners with the youth and the family. And we have to try to understand the youth from their neurobiological, neurophysiological profile, their cognitive and their language background, their physical profile and sensory processing profile. Which is why we need a team. And this is why the information you gather at the beginning of your sessions in all of these areas is so important, so that we don't misunderstand and mislabel behaviors that are really communicating something other than aggression or non-compliance. Okay, next slide, please. So this slide really provides just an opportunity to really frankly acknowledge the complexity of language and to understand that if the children's behavioral difficulties are related to communication deficits, your best bet is to work with a speech language pathologist. And if you are able to get a couple pithy messages from this presentation, the first one would be this: that language is the instrument of thought, and that language and thought are the instruments of self-regulation. So we really, the more we understand about this complex integrated system we call language, the better off we're going to be in terms of being informed and understanding the kind of supports the child might need. So as a speech language pathologist, if we look over at the far left box, we will always, first of all, start with looking at the child's acquisition of the linguistic code. So we're looking at phonology, which is the sound system of language, the child's ability to understand and use words, the child's ability to use word endings, the grammar, how they put those words into order, which is referred to as syntax, and then the child's understanding of all the ways we use language to communicate, to really understand the power. But it doesn't stop there. That is just one part of language. As we know, cognition and the development of the child's ability to perceive, their ability to perceive patterns and develop concepts, uh, to be able to begin to understand that, for example, a cup represents a drink that they will be getting, all the way up to symbolization, which is when the child is actually has the capacity to use language or to use symbols. And when we say symbols, we mean words, we mean sign language, we mean text. So you can see that interaction between cognitive development and language development or linguistic development, and those two areas inform one another. So if we see a child, just as a real quick example, so that you understand how the interaction occurs, if we see a child who has very, very, let's say, behavior such as throwing and running away, um, it may appear, gee, how can we help the child express his protesting other than by throwing and running away? Maybe we can, teach him some words. But really, for us as a speech language pathologist, I'll be assessing the child's developmental level and um, really at that point understand that the child is not at a level for symbolization, and not at a level where they're going to understand words and use words. So teaching words to this child would not be appropriate because they're not at the developmental stage. But this is where they're using behavior to communicate. And so we would need to look at the kind of behavior and how we can replace that behavior with something that is more adaptive and more functional and effective for the child. So that just gives you a little bit of a sense of how development, cognitive and language and cognition go together. And in addition to that, we also look at the internal and environmental factors that impact the child, as well as their performance, that is, their capacity to integrate each of these dimensions and communication in real time. So we, in terms of looking at that bottom dimension, environmental, let me just, yes, thank you. Units of the communication environment. We have both internal drivers that prompt us to communicate, that motivate us to communicate, as well as external drivers, which would be, the stimulation that parents offer their children in terms of, providing modeling sentences, expanding on what the child says in order to promote more language development, as well as reinforcement, where the child understands if he says cookies with that S on the end, he actually is going to receive cookies. So the internal and the both internal and external environment are very important drivers in terms of communication. And Mary Beth will be talking about this a little bit more, but one area that may need to, we do need to consider, and that you both, that you are schooled in, is the experience of trauma. And that may not be something that is obvious, but is an internal driver that we know often can elicit behavior that may appear to be aggressive, but is in response to a traumatic memory. And finally, we have units of language performance. And that is where the child is expected to integrate all these individual processes into a synergistic whole. And we call that the performance. And this is where the child has to put the words together into sentences, have the idea in their head, and be able to formulate a sentence, a narrative, a story, in order to communicate what they are trying to express. And often, if the child is having difficulty with performance, we're going to need to look at both the cognitive portion and the linguistic portions, as well as the environment. If it's a stressful environment, the child may not have access to the words that they normally might have because the environment is really short-circuiting their frontal lobe, and they are not able to find the words that they normally would have. So it really is more than just the linguistic code that a speech language pathologist will be looking at, and that we all need to be aware of as we try to come up with the most informed emotional supports and regulation supports for the youth that we serve. Thank you, Mary Beth. So we talk a lot about social communication, and it's a lot more than a discrete set of social skills that allow us to be polite uh, and compliant. It really comprises three areas. Social interactions, which is just knowing how to engage in the social world. It's knowing what to attend to, what's meaningful socially in terms of the social cues. We know that it's important to look at the eyes, it's important to look at the mouth. So it's that social attention that is a critical part of social communication. It's also understanding how to adjust your language depending upon the task. So it's about code switching. You know, when I talk to my grandmother, I'm going to talk to her in Swedish, but when I talk to my daughter, I'm going to be talking to her in English. It's also about social reasoning, understanding that another person has one perspective, we have a perspective, and the whole idea of compromise, and as one form of social reasoning, which is also under the rubric of social communication. We also have pragmatics, and pragmatics really refers to how we communicate, where we don't communicate too much, we don't communicate too little, we don't communicate in big words when we're talking to a child. We don't communicate too loudly, too softly. We have the right volume. All of these adjustments and ways that we adjust our message to fit the social situation is really all under the rubric of pragmatics. It really is about the child, the youth, understanding all the different ways that we use communication to navigate ourselves in the social world. And then finally, we have language processing, which uh, is the ability to pull together what is happening in our social world, what is being said, what is being shown, and being able to process that information, understand that information, as well as to be able to process all of this simultaneously, have our ideas, and to be able to formulate them in an ordered, sequential manner that's cohesive and understood by those who are around us. And then, as a part of all of that, we have, you can click the slide, Mary Beth, just, yeah, great. Social cognition. And when we're looking at social cognition, it's the integration, it's social communication, integrating kind of this set of developmental processes that are inextricably linked to social cognition. It's our social mind, and our social mind goes with us wherever we go, so that we can figure out how to interpret the social world, how do I respond to this? Why is this important? Um, and it helps us in terms of figuring out how we're feeling. Really being able to focus on how we're feeling and recognizing and naming that. And you can go ahead and click on one of the just ability to name our emotional states, being able to recognize them in others, as well as being able to not only sense what's happening inside of us, understand it, know how to name it, but then also what to do to regulate ourselves. And just one more. Thanks, Maribeth. And how to do that in a way that is organized and effective. So this is what social communication and social cognition is all about. It really is the language of emotional regulation. And it really is the wheelhouse of speech language pathologists and occupational therapists. You can go on, Mary Beth. Thanks. So this slide is really just to a quick review of the core autism traits. If we look at the two inner circles, there are in children or youth diagnosed with autism, difficulties with social communication, social interaction deficits, as well as restricted repetitive patterns of behavior. And these, I wanted to highlight them because it really affirms the diagnostic and therapeutic role of an occupational therapist and speech language pathologist. But we also know that the majority of children, youth, and adults with autism also have the experience of comorbid medical and behavioral challenges. And so again, just looking at all of the different areas, the morbidities in terms of anxiety, hyperactivity, impulsivity, agitation, aggression, also the medical comorbidities, including the GI. We have seizure disorders. We have genetic disorders. All of these, and then finally cognitive comorbidities. And all of these remind us, just this graphic, the critical nature of a well-coordinated team, and that we are each players in a very complex system. You can go next. So before we go on to talking more specifically about specific emotional regulation strategies, just wanted to mention that our definition of emotional regulation, there are many, but the one that is most familiar to me is really seeing it as a core developmental process that impacts how we attend to the social world around us, and how we engage in the social world and remain emotionally regulated. And to recover from extreme dysregulation, we use two strategies. And you, going into this crisis situation, will be a mutual regulator. There are two different strategies: mutual regulation and self-regulation. And mutual regulation, I guess we can go, yeah, yes. So in terms of the developmental stages of emotional regulation, I had mentioned earlier that these stages are really contingent upon the development of cognition and language. And we start out our young infants as with behaviors. We use sensory motor strategies to soothe ourselves, whether it's vocalizing, seeking oral sensory input, engaging in repetitive motor actions. All of these are in service of keeping ourselves regulated. And we still do these. We start out with the behavioral strategies as being our only strategies, but we don't surrender those. As we get older, we continue to use behavioral strategies, such as chewing gum, for example. But we also develop language strategies. And again, language, including the use of words, the use of text. We can use photos and line drawings to help us regulate, using things like calendars. Using our words to be able to express how we're feeling, how we're thinking. And this is why language is such a critical part of self-regulation, because it is a more sophisticated developmental process that allows us to effectively communicate our needs, and in so doing, being able to help ourselves stay regulated. And then finally, there are the metacognitive strategies to remain regulated. And these are the strategies, this is the developmental stage where cognitive behavioral therapy is appropriate. This is the stage where we're able to think about thinking. We're able to think about what we're thinking about, and how we can stay organized. What do we need to do for ourselves to remain self-regulated? And this is where we're really at a point where we can look at others and take their perspective, as we simultaneously take our own perspective, make some judgments about that, adjust our tone of voice. And it's where we are at a stage where we can do critical thinking. So we'll talk more about that. We can go on. Thank you. And so in mentioning the emotional regulation strategies, there are two main ways. The mutual regulation strategy occurs within the context of social interactions, and it's the person-to-person adjustments that we make while we're interacting with the individual. Self-regulation is the independent use of emotional regulatory capacities to remain well regulated. So one is person-to-person supports, and the other one is being able to initiate strategies that we are able to use to regulate ourselves. And we often will start with mutual regulation strategies with as adults, as we're modeling for children. And over time, the children then assume responsibility for these mutual regulation techniques and begin to do them for themselves as self-regulating strategies. Okay, next slide. And then there are two different kinds of emotional regulation strategies: interpersonal or interactive. These are the person-to-person adjustments that we make. I might talk slower. I might talk quieter. I might talk lower. All of these things to help support the regulation of another person. So it's about the adjustments I make in interacting with the other person to help remain emotionally regulated, them and me. And then learning supports are used to our organization arrangements in the environment, such as a chill room. It might be visual supports, such as a calendar, a schedule, anything that will help us understand time and space, and time and space. So I think at this point, the next slide is Mary Beth's.